This is group number 8's presentation on amyotrophic lateral sclerosis, presented by Carrie Joyce, Courtney Kessler, Sam Lee, Spencer Mock, and Casey Nance. ALS remains to have no known cause. ALS is categorized into two types, and both have speculated causes. The causes could be familial or sporadically acquired. Sporadic ALS involves multiple steps, such as a parent passing a mutated gene to offspring, exposure to dangerous environmental substances, or gene expression of mutations, allowing ALS to progress. Exposure to harmful toxins and increased dietary intake of zinc, animal proteins, and sodium have also been linked to ALS. Exposure to these toxins, however, could occur for several years before developing ALS. A combination of exposure to environmental factors and mutated genes calls for the greatest risk of ALS in the future. Description of ALS. ALS is also known as Lou Gehrig's disease. It is fatal and progressive, but in the early stages, ALS is difficult to diagnose because symptoms may be similar to other neuromuscular disorders. Degenerative disease affecting upper and lower motor neurons, and degeneration is also found in the corpus callosum, extramotor cerebral regions, and the prefrontal lobes. The neurons stop sending signals to the muscles, which lead to paralysis, but the actual mechanisms of neurodegeneration remains a mystery. Paralysis can become present in skeletal muscles, which control breathing, movement, swallowing, and speech. Characteristics of ALS. So ALS is a very sad diagnosis because of the progression of the signs and symptoms. In the beginning stages, a person will have hand weakness or foot drop and could have cramps throughout the night. Muscle loss, like I said, is progressive. Spasticity in the lower and upper extremities are common, and fasciculation, or the flickering of muscles under the skin, is also common. Difficulty speaking and swallowing, emotional control, loss of emotional control, and difficulty regulating body temperature are noted in the later stages, as well as distal and proximal muscle loss, respiratory failure, and ocular motor palsy. Recent studies have indicated that nearly 1/3 of people with ALS demonstrate significant cognitive defects and reduced executive functioning and planning skills. Within this slide, I really wanted to show where some of these symptoms actually lie. So breaking up in between the lower motor neuron, corticospinal tract, and the corticobulbar tract. Within the lower motor neuron, this is where focal weakness, atrophy, muscle cramping, and twitching will be seen. The corticospinal tract, we have spasticity, hyperactive reflexes, dysgraphia, and dysarthria. Dysgraphia can be described as difficulty swallowing, and dysarthria can be described as impairment within speech quality production. Within the corticobulbar tract, we also will have dysgraphia and dysarthria. Here's a nerve cell comparison. In the picture, on the left side of the picture, you will see a normal nerve cell with healthy dendrites, nucleus, cell body, and an axon leading down to a strong, healthy muscle. And then on the right of the image, you will see the dendrites, the nucleus, the cell body looking very puny, weak. And if you follow down to the axon, you will see how it leads to atrophied or damaged muscles, and this is what is present within ALS. The effects on the normal structure can vary based off of how far along the individual has progressed in their ALS journey. But a person in the beginning or mid stages of ALS could have difficulty in all of these areas, minimal to mild difficulties in all of these areas, including ADL completion, with strength, brushing their hair, washing their bodies, dressing themselves, IADL completion with cooking-based tasks, planning and sequencing cleaning around the house, and taking care of a child or a pet could be difficult. As the progression of the disease continues, increased assistance with health management may be necessary for scheduling appointments, driving the individual to and from appointments, manipulating medication bottles due to decreased strength or dexterity. Rest and sleep is hindered by muscle cramping, and some individuals may develop insomnia. Work performance could be limited by decreased motor movements, poor communication, and independence within their daily tasks. In this category, it could be very beneficial for the person to engage in some type of hobby identification in order to find some hobbies that might spark interest and increase positive self-thought. So play and leisure may be affected by poor motivation, increased fatigue, and decreased mobility capabilities. And finally, changes in communication, mobility, cognition, and sexual dysfunction may impact social participation. Overall, with this diagnosis, a huge factor is cognitive state of mind. Working on mental hygiene is extremely important to encourage quality of life and positive self-thought as the individual adjusts to this diagnosis.
In this slide, I'll be discussing the incidence rates and statistics regarding ALS. So the incidence rate in the US is 1.5 individuals per 100,000, and the prevalence rate is estimated to be between 5.5 and 9.9 per 100,000. Just to quickly clarify the difference between incidence and prevalence rate, because I had to look at it myself. The incidence rate relates to how many people are diagnosed with the disease within a certain time frame. For this time frame, it was within 1 year, and then the prevalence rate is how many people are estimated to have that disease within 1 moment. And then ALS is 1.56 times more common in men than women, and the largest risk factor for ALS is being a white male in his 60s. So the odds of being diagnosed with ALS increases with age until the age of 80, then it decreases. There are instances of people being diagnosed with ALS in their 20s and 30s, but this is rare. And there are a lot of theories regarding why people develop ALS, but there's no proven reason. But some of these theories regarding the environmental risk factors include exposure to heavy metals, pesticides, military deployment, or BMAA. I'm not going to try and pronounce that. This would make sense for males developing it. Majority of people who have military deployment are males. And historically, these industrial jobs with exposure to heavy metals have been male dominated. And then agriculture as well. Regarding BMAA, that is a neurotoxin that is produced by a number of different sources, but the most common one that we run into are algae blooms. And there's an association with ALS and Alzheimer's and BMAA, although this is just a correlation. It's not been proven to cause it at this point. And then this neurotoxin BMAA can end up in shellfish. So there's a theory that eating seafood that's contaminated with a neurotoxin can increase the risk of developing ALS.
Lateral sclerosis diagnosis is an unfortunate and devastating disease that can be difficult to diagnose. Diagnosis is determined first with the exclusion of other conditions and the primary source of a clinical examination, laboratory test, nerve conduction studies, and electromyography studies. Exclusion of other conditions with similar symptoms could be autoimmune disease, myasthenia gravis, multiple sclerosis, Guillain-Barré syndrome. Genetic conditions could be bulbospinal muscular dystrophy, oculopharyngeal muscular dystrophy, infection-related problems, HIV, post-polio syndrome, nutritional problems, vitamin B12, copper syndrome, hormonal issues, elevated thyroid hormone, parathyroid hormone, hyperparathyroidism, and neurological problems, Parkinson's disease, stroke, and damage to the spinal cord. This is one of the most understood conditions in the world of clinical neurology when discussing the diagnosis, the anatomy and physiology for amyotrophic lateral sclerosis. The needle EMG test can be used for acute and chronic denervation and could lead to a diagnosis before receiving evidence of clinical onset. Needle EMG doesn't specifically identify ALS and must be completed with extensive denervation with multiple distal and proximal muscles. The EMG test is used to differentiate ALS from other conditions by determining the presence of muscular degeneration. Earlier, I talked about how ALS is diagnosed. This is just a picture to show the different options that can be completed. As it says, there's no single test to confirm an ALS diagnosis. Some of these can aid in diagnosing disease. The nerve conduction study, which measures the speed at which nerve cells transmit electrical impulses. There's electromyography, records the electrical activity of the muscle at rest and during muscle contractions. There's an MRI, which produces detailed images of structures inside the body. The muscle biopsy, it detects abnormalities in muscle tissue. And lastly, the spinal tap, which provides information about inflammation and damage in the brain and spinal cord. As research, this test can be used for research purposes to help with a diagnosis of ALS. Magnetic resonance imaging of all regions used to evaluate the brain, spinal cord, and to visualize changes in the muscle tissue. Magnetic resonance spectroscopy, diffusion tension imaging, transcranial magnetic stimulation. The patient has malignancy, Lyme disease, chronic inflammatory myelinating polyneuropathy, and HIV. A cerebral spinal fluid analysis should be considered to obtain a CSF protein profile. Muscle biopsies can be performed for patients who have possible myopathy. The diagnosis with the L-Escorial criteria, which was developed as the main parameter to diagnose ALS, to have a consistent diagnostic process that guarantees certainty and can clarify the varying clinical qualities that may be complex. L-Escorial criteria requires at least one of the following: the progression of upper motor neurons and lower motor neurons dysfunction in at least one limb or body region, or lower motor neuron dysfunction in one region identified by a clinical exam and in or two regions, lumbosacral, bulbar, thoracic, or cervical. I'm a visual person, so I wanted to give you a slide to show the revised L-Escorial criteria for ALS and to be able to show how it's definitely diagnosed versus the possible regions that are affected.
Now we're going to talk about medication treatment for ALS. There are two FDA-approved treatments at this time. The first one is Riluzole, which is a glutamate inhibitor. While it does not have effective significance in relieving symptoms, it does prolong an individual staying in a milder stage of the condition, and it increases survival. Overall, it increases survival by 3 to 6 months, but other studies have reported anywhere from 2 to 3 months or 6 to 21 months for lower class trials. One study completed in the 90s showed an increased survival from 58% to 74% after 12 months of medication use. Next is the second FDA-approved medication, which is Edaravone. It decreases oxidative stress. Now, this medication has been shown to slow functional decline, and it seems to be more beneficial for those in the early stage of ALS. And by early stage, this is regarding for those that have experienced symptoms for less than 2 years. A study showed a 33% decline of function following a 24-week follow-up. However, this medication is very expensive and can cost an individual up to $146,000 per year. Other treatment options that we're going to discuss are addressing symptoms such as pain, muscle spasms, and sialorrhea. First, pain can be addressed through the use of anti-inflammatory medication or opioids. Muscle spasms can be addressed through medication as well, with the most appropriate being mexilatine, which is shown to have a good response. Sialorrhea is the excessive drooling or saliva that an individual experiences, and this can be addressed through injections into the salivary gland or even low-dose radiation therapy. Other management strategies of ALS could be potential stem cell therapy. Overall, a multidisciplinary team approach to this condition can be super effective in improving the quality and life of the individual. Now, this team could consist of nurses, occupational therapy, physical therapy, neurologists, speech therapy, nutritionists, and more. And last is palliative care. This type of care is going to be known as comfort care and comforting the individual to manage the symptoms of this condition.
Prognosis. The course of ALS is usually progressive and rapid. Life expectancy in ALS is extremely variable between the patients. The duration of survival is 2 to 5 years after the initial onset of symptoms. 50% of the people diagnosed with ALS from initial onset dies within the first 30 months. The life expectancy is determined by the ALS or rate of disease progression. There are some instances where someone with ALS will show improvement and live longer than 10 years. 10% of death occurs from respiratory failure. What happens if patient receives treatment? Managing symptoms including occupational therapy, physical therapy, speech therapy, and respiratory therapy to prolong and maintain functional abilities. Light exercise to maintain muscle strength and function. Heat and whirlpool therapy to ease muscle cramping. There are 2 Food and Drug Administration approved drugs to treat patients diagnosed with ALS. Both drugs, Riluzole and antioxidant Endavalone, can prolong life up to 2 to 3 months. What happens if patients go untreated? Most individuals diagnosed with ALS onset of symptoms will die within 3 to 5 years from respiratory failure if untreated. As the disease progresses, muscle weakness and breathing becomes difficult. Depending on the progression of the disease, feeding tube might be required. The last stage, the muscle becomes paralyzed, loses the ability to speak and move. The later stage ALS will need hospice care followed by death.